Okay. Oh. All right. Let's see. The sound okay? Good. Can the remote students hear me? I have the chat open. But yeah, but yes, perfect, perfect. Yes, yes, yes. Wonderful. Can you see the presentation mode of the PowerPoint remotely? Yes, wonderful. All right. Okay, I turned off my video. If you want to prefer having that on, I can take it on, but it might be just distracting. Oh no, that's weird. Okay. All right, so welcome everyone to the second T-cell immunology lecture. So how was the neuroanatomy test? It was fine, but more things about it. It's done. I'm not sure if I still can do that. So I can understand that you guys are a little bit tired now. So relax, we will discuss a clinical case today. So it's not as heavy on additional information. And but before we do that, let's see if that, I probably have to do this with my mouse. A little bit slow. Here we go. So I want to review a little bit what we discussed last time, some important points to highlight. And we'll talk a little bit about corgis today in our clinical case. So before we do that, let's review a little bit what happens to T cells in the thymus. And there are some things in that lecture that you may not have yet in your materials on ELC, but once we finish the session, I can post the entire presentation here also with some additional information on ELC, so you don't have to write everything down. Okay, so what happens with T cells once they migrate in the thymus? They're all born in the bone marrow as kind of these very early T cell progenitor cells. And at that stage, there is still what we call double negative. That means there's no CD4 and no CD8 expression at this stage. Then they migrate to the thymus. And first, what they do in the thymus, and then we call them thymocytes or T cells, they use a random rearrangement of different segments in their T cell receptor. Again, that's the receptor that recognizes the antigen, to add a lot of diversity to different types of T cells. So we call this random rearrangement of T cell receptor cell genes. The next step, at this stage, they're double positive. And then they undergo what we call positive selection in the thymus and the cortex, like superficial in the thymus. And what it means when it comes to positive selection is that positive selection eliminates self or non-functional T cell receptor, or T cells with a non-functional T cell receptor that wouldn't recognize anything because these are useless. And it also determines if a double positive T cell will get or develop into a CD4 T cell or into a CD8 T cell. And that's based on interaction with different MHC molecules. So those that don't recognize any MHC molecules on antigen presenting cells, they would be eliminated. They usually die by apoptosis. And those that interact with MHC2, what do you think those would develop into? Which type of T cells? Yeah, T helper, CD4. And those that would interact best with MHC1, they would further go down the CD8 cytotoxic T cell route. Then those single positive T cells then are undergoing what we call negative selection. So they are kind of challenged by self-peptides that are presented in the thymus to them. And if they bind too tightly with those MHC molecules with the self-peptide, they also get eliminated. They usually die by apoptosis. I cannot see the chat, by the way, anymore, so it disappeared. So, that, here we go. Is that better?
Yes, that's.
Let me briefly try to. Yeah, they probably see the presentation mode. So maybe what I can do. Okay. And that happens a lot once my laptop is usually connected to the monitor here. So let's see which one. Maybe this one. Is that better? Okay. Can they still see just one slide now? Okay, perfect. Okay, let me click where we were. Here we go. Okay, we'll talk about negative selection. And those T cell receptors that would bind too strongly would get eliminated. And then basically what leaves the thymus are either CD4 positive T cells or CD8 positive T cells. They're not fully matured at this stage yet. We still call them naive T cells. And then they migrate to the lymph node. And if you're interested, I included a video here that kind of nicely explains with a cartoon how the T cell selection process in the thymus function. And you can watch that if you like at home or later after the class. So what happens next in the lymph node? So those naive T cells then need to get activated, and that usually happens when they recognize an antigen or a peptide that's presented by MHC2 or MHC1 on a dendritic cell or any other antigen presenting cell. In a lymph node, it's usually a dendritic cell. Then they go clonal expansion and differentiation into a certain type of effector T cells. And then they exit the lymph node and migrate to the site where they're needed. It's usually the inflammatory site or where the antigen, infectious agent, or pathogen usually resides. Some of those effector T cells might stay in the lymph node because these are needed to help B cells to produce certain antibodies and helps to differentiate them into plasma cells. And we call them T follicular helper cells. Okay, so let's talk a little bit about what signals are needed to activate T cells. Do you remember what signals are needed that a naive T cell gets activated into effector T cells? And I already mentioned one. Perfect, cytokines from the environment. That would be kind of the third signal. What needs to happen that a T cell actually starts to do anything? What needs to be present? Yeah, an antigen. And who's presenting the antigen? Yeah, dendritic cells. So basically interaction between the MHC peptide or peptide in this case is usually antigen. That's the first thing that needs to happen. Okay, and then there are some co-receptors that are responsible for signal number 2. Remember those? Maybe there's one on T cells and the other one is on these antigen presenting cells. One is CD28, that's the one on T cells. And then the other one is CD80 and 86 on antigen presenting cells. So these are the 2 first signals that are needed to activate a T cell. And then the third one is we need cytokines. One of them that is very important, that's kind of always part of it, is IL-2, because that's the one that's necessary for proliferation and clonal expansion, so that that T cell that has the most specific T cell receptor gets selected and can expand and further proliferate. And then we have some other cytokines that kind of depend then, they kind of then are responsible for the fate, ultimately, what this T helper cell will be at the end. Meaning we have different types of T helper cells. So first they all start with these naive T cells and then they get activated, and that depends a little bit on the overall, I call this here, inflammatory milieu or environment. So basically what cytokines are present. You remember some different types of T helper cells? They first start in a very logical order, and then they kind of get out of order. One is T helper cell 1. So what's the other one? Yeah, very good. And then there are T helper cells that we call T helper cell 17. That really doesn't make sense because that's kind of out of order, but this is how they're assigned, T helper cell 17. And these are often part of inflammatory reactions. And then we have T follicular helper cells. These are the cells that help B cells to proliferate, to mature into plasma cells, and also responsible for switching antibody classes from IgM to IgG or IgA. And then we have those that are more immunosuppressive. These are our regulatory T cells or Tregs. So usually what happens is from the naive T cells to the effector cells, we get a very specific response. And the effector cell also starts to proliferate and to expand in a clonal way, that we have one T cell that's specific to the antigen and expands. Ideally, we want to have a memory function of these cells. So there are cells that are producing cytokines and can help eliminate a pathogen or an antigen. And then there are cells, especially our cytotoxic T cells, that can kill directly cells. So if we look at those from the beginning to the end, we have those naive T cells that start out very diverse, very different types of T cell receptors. And they migrate to a lymph node. And then they're kind of just waiting for an antigen to come in and to be selected that I'm the one who's actually fighting that antigen. Once that antigen is identified, they then develop further into effector T cells. So they're much more antigen specific, and they may rather than reside in tissues, and they may produce certain cytokines that protect against the antigen or fight the antigen, or they may kill an infected cell directly if they're cytotoxic T cells. So these are our effector cells. And then we also have some of them that kind of after they did their job, go in a certain stage of silence, and we call them memory T cells, but they have to be exposed prior to a certain antigen. And once that antigen kind of shows up again, they can mount a very effective and fast response. So these are our memory T cells. They're basically kind of the renewal cells that respond again if the antigen enters the host or the body again. Similar what we would need when we get vaccinated. Okay. Are there any questions about these different types? Anything in the chat? Good. Okay. All right. So let's talk a little bit about our clinical case that we have today and that we want to discuss. So let's imagine you finished vet school, you did an internship and a residency, and now you are an internal medicine specialist here at UGA. Sooner or later, you will get there, I promise. Doesn't feel like this right now, but yes, you will. And this is your patient here. This is our little corgi puppy. And he presents to you with a history, like the breeder actually is bringing the puppy in, with a history of failure to thrive, diarrhea, and intermittent vomiting. When he was 8 weeks, and so at presentation, he's already 14 weeks, but when he was 8 weeks, he was actually the largest of the litter. Something's changed during that time. So what can you think of, but what additional question would you like to ask the client? Has there been any environmental changes? What do you mean with environmental change? Did they move maybe from inside to outside, potentially exposure to some infectious agents? Yeah, that's a good one. How's the puppy's diet? Very good. What is he eating? Because he does have some GI signs. When was he weaned? Yeah, he's 14 weeks old now, and then kind of at 8 weeks, there was something obviously still all right. So he was weaned around that time, between 8 and 10 weeks. And is now on kind of normal puppy food. Good. Are any of the other litter mates affected? Because he's so young. So we think about something either infectious or that kind of could be maybe affecting the entire litter. Yeah. Has he been dewormed, or is anyone else in the household sick? We think about something maybe zoonotic. Yep. Good. Has she or he experienced that with any of her other litters? That's the first time they're breeding. It's the first litter. Anything you want to know maybe about the parents? Like did kind of his parents experience anything like this when they were younger? Had the puppy postnatal care. So everything went fine during birth. There were no obvious complications. They were all nursing fine. But what did happen is another puppy died, and they don't know why. When the puppy, have they been vaccinated? Not yet, but the parents are. So these are all excellent questions. Wonderful. Let me go through this. So one thing we didn't discuss is what happened between 8 weeks of age and 14 weeks of age. So this is kind of where those clinical signs started to progress. What do you think what happened with the puppy during that time? And someone asked the question. What happens with puppies between 8 and 12, 14 weeks? Yes, weaning. It's usually weaning. So they may not have, they're not on a milk-based diet. They're not on protective antibodies anymore that they usually ingest with nursing. So that's something to consider. Parents are full vaccinated. The first time they were breeding this pair together. One brother of this puppy died, and they don't know why. It kind of happened unexpectedly. And interestingly, a male cousin also had similar clinical signs and also died. And then, since the dog is sick for a few weeks, would you want to ask about maybe certain treatments? Because it was referred. So the RDVM did a parvo test. You're familiar, right, with parvovirus? Yeah. So it was a fecal snap test, and that was negative. Also did a fecal exam to look for certain underlying parasites, was negative. And since the dog had diarrhea and was vomiting, was probably a little bit dehydrated. He was put on IV fluids and then sent to UGA. All right, so let's do a physical exam, right? These are some physical exam findings. I'll give you a little bit of time to read through this. But what we can tell is that the temperature was increased 104. And the other thing that was kind of remarkable is they couldn't find any lymph nodes. So there are some palpable lymph nodes usually that we always find. These are the mandibular lymph nodes in a dog, and usually the pre-scab lymph nodes and the popliteal lymph nodes. So those that are kind of sit behind the knee, those that are in front of the shoulder, and those that are kind of here under the mandible. They couldn't find any in this dog. And then he was also pretty poor body condition, so he lost a lot of weight. So if we would kind of summarize this as what do we know about problems from the history? What do we know about problems from clinical science? What would you put on a problem list here? Yep, diarrhea, vomiting. Yes, the family history that another puppy died, and then the cousin that died. Probably also the failure to thrive, which is a little bit more general, but it's something we want to definitely put on our problem list. Lethargy was mentioned, especially for a puppy. Usually puppies are very playful and very energetic. Diarrhea, vomiting, sudden death of brother, similar illness in a cousin. And when we asked more specifically, it was actually from the mom's sister, a puppy who had similar clinical signs and died. Okay. From our physical exam findings, what would you put on a problem list? Fever. And then something that was actually not present. Yeah, the lack of lymph nodes, which is weird, but we want to put that here because it's a physical exam finding. We would expect to find it, but it's not there. Okay. So are you familiar with the vitamin D concept when it comes to how do we approach a problem list and how do we decide what next diagnostic test we want to do? Okay, perfect. So what test would you like to do next in this dog? A kind of a test that gives you kind of an overall summary maybe of his health. CBC chemistry, very good. This is what I have for his CBC. And we also, at this stage, already included, since we kind of suspected there might be something wrong with the immune system, we measured some immunoglobulins. So we have a lymphocyte count here, different concentration of immunoglobulins. On the CBC, there was also an increase in neutrophils, but no immature neutrophils, so no band neutrophils. That would be usually, that's something we would see with inflammation, but that was not necessarily present. And the chemistry profile was normal. So looking at these results that we have here, what do you see? This is a reference interval, and this is our patient result. Yeah, that's a lymphopenia. Very good. Yeah. So the opposite of a lymphocytosis is a lymphopenia, so decrease in a lymphocyte count. Then our IgM here, immunoglobulin M, is 182, and our reference interval is from 90 to 140, so that looks normal, right? Or even a little bit increased. However, when you look at IgG and IgA, they're both lower than our reference interval. So 600 for IgG, and it should be at least above 900. And then IgA is less than 10, and it should be at least above 15. So what does that probably imply? Very good. So what is the difference between an IgM and an IgG? When do we see IgM in the time course of any antigen exposure? Very early on, right? And then we would see a class switch to IgG or IgA, which apparently here may not happen. Okay. Are there any questions in the chat? Good. All right, so when we now put all of these findings in kind of a master problem list, what would you put in here? Very good. Yeah, we want to leave probably lethargy on, failure to thrive, vomiting, diarrhea, we have fever, we have a neutrophilia, and a lymphopenia. And what else was on those laboratory result? Mm-hmm. Yes. So if we want to put a term into this, we call this hypoglobulinemia, except for the IgM. So a decrease in gamma and a decrease in IgA globulins, IgG and IgA. Okay, so let's go back again to our differential diagnosis list or to our vitamin D rule out list. Do you think this puppy may have a vascular disease? Like a stroke or something like any vascular abnormality? Likely not, right? Do you think this could be something infectious or inflammatory? Maybe, yeah. I mean, it's a puppy and probably not fully vaccinated. And something happened between the time he was weaned and then kind of started maybe to make his own antibodies, and that may not have been working. Trauma or a toxin? Unlikely, because that wouldn't go over like 3 or 4 weeks, right? Any anomaly? What do you think? Maybe? Yeah, maybe. So if we think it could be genetically or inherited, yes, then maybe we could believe it in that category. It's a little bit unusual that he was normal apparently at 8 weeks and then was sick again at like 13, 14 weeks. Anything metabolic, like endocrine disease or something that would affect his glucose metabolism, liver? Yeah, the chemistry panel was normal, so probably unlikely. Our favorite group, iatrogenic or idiopathic. So basically, if we don't know anything, then that might be that. Probably a rule out diagnosis, right? Nutritional? Probably not. And then we would probably see often what we see on a chemistry panel with nutritional deficiencies is like abnormalities and have calcium and phosphorus when that is not balanced in the diet. What do you think about neoplasia? The puppy, it's very, usually in most neoplastic diseases, there are a few exceptions, rather affect older animals and not really puppies. Never seen neoplasia in a puppy, at least not a malignant neoplasia. That is correct if you think about a specific type of neoplasm like lymphoma that occurs from lymphocytes. Yes, then the question was if this would be lymphoma, would we still expect to see IgM but not IgG or IgA? Likely not. Very good question, yeah. And then degenerative is something like, speaking of neuroanatomy, disc protrusion, probably not any bone diseases, joint diseases. He's probably a little bit too young for that. Okay. So at this stage, we probably think that something infectious or inflammatory is most likely. So what would you think would be a likely reason for his disease at this age with these symptoms? in these findings. Yeah. 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 So what category do you think would that be? Kind of. Yeah, very good. I mean, immunodeficiency. Yeah, very good. Given the age, the symptoms, kind of how it also affected other litter mates or kind of relatives like a cousin and a brother. So we probably think about some kind of immunodeficiency. Very good. Mm-hmm. And then you could think of, could this be a primary immunodeficiency given the age, or could this be caused by some kind of infection? For example, like a parvo infection may present with similar signs, but probably not over a long period of time. It might be more acute. So they can have vomiting, they can have diarrhea, they can have a lymphopenia and things like that. But that would be over several days and not over 3 or 4 weeks. And then any kind of underlying other severe disease, like an underlying neoplasm, can cause secondary immunodeficiency, but that's very unlikely in this young dog. So if you think there's something primary genetically, is there any thoughts about how you would treat this dog or what additional diagnostics could be done? Very good. Yeah, we would test other litter mates. Obviously, we would then need to know if there's something specifically in this breed that we can test for. Are there any genetic screening tests that we can test for specific mutations? Very good. Mm-hmm. There are certain drugs. The question was, can we give immunostimulatory drugs? There are certain drugs we can give, and some are more specific. We can give immunoglobulins, for example, but it wouldn't last that long, obviously. And some are very unspecific and would maybe stimulate the entire immune system. Very good. So the kind of the thought was, well, when we think about an immunodeficiency and there's something wrong with the B cells, is there something wrong with the bone marrow? And then secondarily, something wrong with the thymus and the lymph node. So anything that would affect B cell or T cell development. Very good. You know what they would do in human medicine if there would be a primary immunodeficiency? Maybe that would start in the bone marrow. They would do a bone marrow transplant, which there are some approaches in veterinary medicine where they looked into that primarily for cancer, and they have been better or successful. And it's also very, very pricey treatment, obviously. It's very expensive, and you have to isolate those animals over a certain period of time, which can be very difficult in a puppy. So the owner or the breeder, the first question they ask, should I euthanize my dog now? Several things were discussed, like bone marrow transplant, gene therapy is something they also do in humans, but all of this is more experimental done currently in veterinary medicine and not necessarily as an affordable treatment approach, obviously. We talked about genetic testing to determine the cause. There are certain immunodeficiency disorders that we can test for. We can test the parents. We can test also the siblings. That would be obviously useful. And then we also have to talk to the owner or to the breeder about further considerations of breeding if this turns out to be a genetic defect. So let's see what happened to our puppy. He unfortunately died. However, it helped in a sense that we could get a little bit more information because we were able to do a necropsy. And on necropsy, we still couldn't find any lymph nodes and also no tonsils, which are kind of doing the same job as lymph nodes do. The thymus looked kind of dysplastic and very, very small. And there were also some foci of inflammation in some organs, like pancreas and the spleen, which could have been maybe secondary because of the severe immunodeficiency that the dog had. They did before were able to get a little bit more blood and stimulated the puppy's lymphocytes with the most potent T cell stimulant, the IL-2. And that showed that those T cells were unable to proliferate. So they didn't proliferate and they didn't expand. And then when they further looked histologically or like on histopathology, looked at the thymus, that there were actually really little to almost no T cells in the thymus. And that's very unusual in a very young dog. So I can tell you ultimately the puppy got diagnosed, and also kind of when we did more investigation about the litter mates and the cousin and the breeding, with what we call severe combined immunodeficiency, or SCID. It's a pretty rare immunodeficient disorder. Most immunodeficient disorders are rare in our animals, but that's one that does affect certain dog breeds. It's a genetic disease, and it's often linked to the X chromosome, which means that female dogs are the carriers and not affected because they have a good copy and a bad copy. But male dogs are usually affected, and that's why we see the disease or the kind of clinical signs only in male dogs, and they often, unfortunately, die, mostly of secondary infections. And that happens usually between the time they're weaned, when they're supposed to make their own antibodies, but they cannot. And then this is the period where they usually get sick. And it's caused by a mutation in the IL-2 receptor gamma chain. So what do you think, how does a non-functional IL-2 receptor result in immunodeficiency? And one was already mentioned when we talked about what they did with the puppy to kind of diagnose the disease. What do we need IL-2 for again? Yes, activation of T cells. And then also expansion, clonal expansion of T cells. So that definitely would not work. And the IL-2 gamma chain is also called the common gamma chain, and it's part of the receptor for other cytokines, and only IL-2. It's kind of the main one, but there are some others that also stimulate that receptor. IL-4, 7, 9, 15, and 21. So that means in these dogs that all T cell responses are almost absent, which obviously would lead to multiple infections that they cannot fight against. They usually have normal numbers of T cells, and that's why we see that IgM was normal in this dog. But these T cells, these B cells are not as functional because they need still help from their T cell friends to proliferate and mature into plasma cells and produce certain antibodies and switch to other antibodies. And that's the reason why IgM is normal, but IgG and IgA was low because they cannot switch antibodies, those B cells, without their T cell help. That is a disease that kind of got a little bit more into the public by this boy that was David, and he was known as Bubble Boy. So he had SCID, and the reason why he was known as Bubble Boy because he lived really in a kind of a bubble that they created for him to protect him from antigens or pathogens from the environment that would not really bother any healthy individual with a normal functional immune system, but his immune system was basically so dysfunctional that they needed to protect him, and this is what they did. They put him in kind of a bubble, almost like a little astronaut. We do see SCID in the Corgi and also in Basset Hounds. That's the same mechanism as in Corgis. That's usually the IL-2 receptor. And then we have a SCID disease in Jack Russell Terriers and also in Arabian horses. And that is a little bit different because that would affect not the IL-2 receptor, that would be a mutation in a DNA-dependent protein kinase. And here I included the question, how would their SCID look different than those with a mutation in the IL-2 receptor. And then you need to know that the DNA-dependent protein kinase is an enzyme that they need for their T cell receptor rearrangement. So basically what's different between the SCID and these different breeds is that those that have the mutation in the protein kinase, the defect would occur much earlier on during the maturation of B and T cells when they rearrange their receptor. So in these animals, they are not only T cells are affected, so they also have a pretty severe defect in B cells. So they have low B cells and low T cells. They hardly produce any IgM, no IgA or IgG. And usually once around weaning, when they're not protected by maternal antibodies anymore, they get pretty severe infections and die. Yeah. They would not produce any functional B or T cells, and they're primarily protected by maternal antibodies they ingest with colostrum early on. And then once they're weaned and that kind of protective mechanism gets lower and lower with time and their immune system cannot keep up with producing anything, then they get sick. Okay. Do you have any questions about SCID, T cell development, T cell function, signaling, activation, anything in the chat? Good. Okay. So what I would do is I will post this, what I had today in the PowerPoint presentation after class on ALC. And if any more questions arise, please let me know and send me an email or find me. I'm usually at the VTH, not here at the CBM. All right.